Hello people. This video is about an important bone and the fractures that are occurring at the site of this bone. And this is the scaphoid. So the scaphoid bone is a very important bone. And it is out of all the carpal bones, the most commonly broken bone in this carpal region. So if we analyze this carpal region and the wrist itself, we have the radius and the ulna. The bones that are above the carpus are the metacarpal bones, the first, the second, the third, the fourth, and the fifth. And in between the metacarpals and the radius and the ulna, we have the two rows of four carpal bones in one row, and so the proximal row has 4 bones and the distal row has 4 bones. So 8 to be exact. This would be, for example, the first row and this the second. This would be the scaphoid bone, and the scaphoid bone has a special blood supply that is very interesting in terms of fracture healing. So if we would see what the names of these bones are, there is a really nice and easy to remember formula. For example, sum for the scaphoid. This is the scaphoid bone. Scaphoid. Then this is the lunate, also an important carpal bone. Sum lowers for the lunate. Then tri for triquetrum, so this would be the triquetrum bone. Positions for pisiform, so this little bone is the pisiform bone. That would be for the first or the proximal row. For the second, so this would be for the first row. Some lower stripe positions. That for this bone is the trapezium. So T for trapezium, or that trapezium. They for the trapezoid, this would be the trapezoid bone for the trapezoid. Cant for this bone is called the capitate. And the last is the hamate or handle for the hamate. So this would be the hamate bone. The hamate bone has this hook called the hook of the hamate. It is also very important because it can fracture. So this would be the second row of bones, the distal. So it is easy to remember. Some lovers try positions that they can't handle. If you remember remember this sentence and the first letter of the words, it is easy to remember the names of the carpal bones, which are actually easy to forget once you pass anatomy. So why is the scaphoid bone so significant? First of all, this is the bone that is fracturing the most, and it has a significant blood supply that is actually not supplying the whole bone at the same time. So an explanation of this, so this is the radial arteria, or the arteria radialis. So if we would look at this picture, so this is actually a lateral view. This would be the radius, and behind it is the ulna, and we have here our scaphoid bone. So actually the radial artery, so I made two, but this is actually all these two branches that are coming to the scaphoid are, so here would be the radial artery, and it is giving two branches. This is one branch of the radial artery, and this is another. This comes from the palmar side, and this from the dorsal side. And they both give off two arteries for the scaphoid, but they give them up on the distal pole. So this would be the distal pole of the scaphoid. So we can see that here. These arteries are entering the scaphoid on its distal pole, and the blood supply is now running down to the proximal pole. So there are no special arteries entering at the distal waist of the scaphoid and at the distal pole. So this arteria is supplying the proximal pole significantly, and this is supplying parts of the waist and the distal pole, and the blood is then going down and supplying parts of the distal waist and the distal pole. This is very significant because fractures that are occurring at the waist and at the distal pole, sometimes because of the disruption in the blood supply, can't heal properly, and that gives rise to non-union and specific problems, especially if this is left untreated in patients that have this fracture. So here are some examples. This is the scaphoid bone. This is a fracture, so here would be the distal pole, and here would be the proximal pole. So this is an example of a tuberosity fracture. So this would be a tuberosity fracture. Then this would be a fracture of the distal pole. So fracture, distal pole fracture. Then this fracture would be a waist fracture. And the last is a type of the proximal pole fracture. So the significance of these fractures is the tuberosity fracture and the distal pole fracture, since they have a good vascular supply, they will heal. But we can have problems if we have waist fractures, especially if they are dislocated and if there is significant damage to the bone. And even worse than waist fractures are proximal. If the proximal parts of the bone is fractured, then we can have also a high percentage of non-union. So if a patient has, and in the clinical setting, the waist fracture is probably seen the most. So how is this happening? So a patient, for example, is walking down the street and slips and falls on his outstretched hand. So fall on an outstretched hand is how it most of the time happens. There are also other possibilities. And what is happening? He's coming into the emergency room, and this is often mistaken for a wrist sprain. So it is often mistaken for a wrist sprain. So this is an insignificant injury because it will heal over time, no matter what you do. But if you miss a scaphoid fracture, and if this scaphoid fracture doesn't heal, and if you don't treat it, there is a high significance of it, this patient will have a significantly reduced quality of life. So imagine if you wake up every morning and you try to do something with your hand and you have pain in your wrist. So this can reduce the quality of life significantly. It won't kill the patient, but it will reduce his quality of life. So if this fall happens, the patient will have similar symptoms as a wrist sprain. So pain, of course, pain in the region of the wrist, and it will be hard to distinguish if it is really a scaphoid fracture or not, but there is a test. So this part of our body here is called the anatomical snuff box. So if I show it on my hand, it is located here. So this would be, if you tell your patient to do a stop sign, so this would be the anatomical snuff box. And if you push into the snuff box, normally, if there is no problem, you will feel no pain. But if you start pushing, even if you touch someone who has a scaphoid fracture, they will feel pain. So if there is pain in the anatomical snuff box, you need to rule out a scaphoid fracture. So you will do an X-ray. Once you do an X-ray, you will probably you always need two views, so you can do an AP view and a lateral view. When you do an X-ray, sometimes, so if there is no special dislocation, this fracture will not show on the X-ray immediately after injury. This is the trick. So sometimes this fracture won't show on X-ray immediately after injury. So you need to immobilize the patient, put them into a cast, and then repeat an X-ray after 10 days. In 10 days, what happens? The osteoblast cells remove some of the broken bone, and you will see a thin line mostly in the waist of the scaphoid. So you can't see this line on the initial X-ray, but if you do an X-ray after 10 days, you will see this line of osteolysis. So, but you taking precautions, you immobilize the patients in anticipation of this fracture. So, the treatment, how do we do treatment of this fracture? There are two ways, obviously. You can treat this non-operatively. For example, non-operative treatment is a cast. So this cast is an under the elbow cast, and it is important to leave the metatarsophalangeal joints and the interphalangeal joint of the thumb open so they can flex. So you would leave these joints open and this joint also so they can flex. The cast would be going here and then through here. So this is important so that these joints are free and don't stiffen up. Once you put this cast on, you already treated the patient. So now the patient needs to wear this immobilization for 6 weeks. After the 6 weeks, you will do an X-ray, a control X-ray to see if there is union. If there is no union, you can do more weeks of immobilization. So, for example, you can do 4 more extra weeks. And if you see that it is not going the way you would like, so if there is no union, this needs to proceed to an operation. So if there is no union, the patient will also feel pain when he moves his thumb and fingers and when he grips things. So that would be one clinical sign, and also radiological, you wouldn't see no real union at the bone fracture site. If there is union, the patient will proceed to physiotherapy, but if there is not, you will need an operation. So what fractures are actually operated at the first time? So if you see a fracture like this, for example, at the waist, that has no dislocation, it is sitting like this, and the bones, the bone fragments are not moved apart, so this is not wider than 1 millimeter, then you will definitely treat it non-operatively. But operative treatment is reserved for fractures that are displaced. So more than 1 millimeter in displacement should be put into a consideration box if it will be operated or not. So if you operate a patient, the bone healing is quicker. So the patient will actually be only, for example, 2 weeks in an elastical band-aid, and they will have the possibility to get to their prior activity faster than a patient who is treated with immobilization. So operative techniques are actually divided. There are two main. Basically, the basic division is the percutaneous technique, is one, and the other is open. So the percutaneous technique is a minimally invasive technique. For example, only 1 centimeter, a 1 centimeter hole is made at the skin, and under X-ray control, a screw is inserted, and this screw is buried into the bone so that the threads are actually not present, not poking out of the bone, the threads in the head, and the threads at the end of the screw need to pass fully this fracture site. With this screw, then you get interfragmentary compression. So this method enables that the healing is much faster, and the patient will much faster return to his normal activities. That is the significance of an operation. And this percutaneous operation gives you also the advantage of not destroying too much of the normal anatomy because it is minimally invasive. If you need to do an open technique is done when this cannot be achieved. So if there are multiple fracture lines and you need to put more material into the bone and you need to precisely do a reposition, then you would need to do an open technique. If there is an operation, the patient's arm is put into a below elbow cast for 48 hours, and after that we will do an X-ray control. If everything is fine, only an elastical band-aid for 14 days is then applied, and in this time the patient can do some controlled digital range of motion exercises, so he can move his fingers. And after this period, actually the active motion exercises can begin. So the take-home point is that if the fracture is not displaced, and if there is no significant destruction of the bone with many fracture lines. So a simple non-displaced fracture is most of the time treated non-operatively. So non-operatively, and it most of the time gives good results. But if there is displacement, especially in young patients, and especially in, for example, elite athletes, and if there is a fracture that is displaced, and if the fracture is complicated, an operation is considered. If you, for example, miss this fracture and mistaken it for a wrist sprain and leave it untreated for a few weeks, the bone will not heal. There will be non-union, and the patient will always feel pain, especially on activity. Thank you.